So I'm Megan Trevino, for those of you who don't know me, and I'm going to be presenting on the physical therapy management of a pediatric patient undergoing correction for a congenitally short limb with anterior cruciate ligament deficiency. So for my 16-week internship, I was at Texas Scottish Rite Hospital for Children in Dallas, and just a little background information about that is that it's a hospital for children, obviously, but they specialize in orthopedic conditions for kids in Texas. Occasionally, they'll take patients from out of the country or from other states, but they predominantly focus on kids in Texas who have severe orthopedic conditions. So the purpose of the case is to facilitate an open discussion regarding successful therapeutic interventions for a pediatric patient undergoing limb length correction while accounting for ligamentous laxity of the knee. So a little background information about limb lengthening, because I had no idea how they would correct a limb length discrepancy. There are three main ways to correct a limb length discrepancy, and that's stimulation of natural growth, acute lengthening, and gradual lengthening. And for this particular patient, they chose gradual lengthening through external fixation, and the specific type of external fixation they chose was an Ilizarov frame. And that's what it looks like. So I had no idea what an Ilizarov frame was. So to explain that in a little bit of detail, the Ilizarov frame, this is computer-generated image of it. Basically, the surgery they perform is they cut the bones, an osteotomy, and then they have two rings that they stabilize using 6 different struts, and then those struts are turned to lengthen the bone. So the bone is cut, it heals, and then they'll stretch it by turning the struts. So it's extremely important these patients bear weight so that they get the full bone formation and healing. And each click of the strut creates 0.25 millimeters of distraction, and the most distraction they'll do per day is 1 millimeter. So it's a little bit of distraction at a time, but it does create a little bit of length over time. And luckily they have a computer system that essentially tells them which strut to turn and what color strut to turn. And so this is my patient's actual turn schedule. It looks really intimidating, but basically every day they'll turn the struts, and it tells him what color to turn and how many times to turn it. So you'll either turn it forwards or backwards, and that helps with lengthening the specific part of the bone and then correcting for angular corrections also. So there's that. And a fun fact about the Ilizarov frame is the bone lengthening that they do. It occurs 6 times faster than the fastest epiphyseal plates in the body. So they lengthen quite a bit really fast in the human body. So now to the actual patient case. So at Scottish Rite, kids are seen as soon as the parent knows that there's some kind of orthopedic condition that's going to need to be corrected. So for this particular patient, he was 1.5 years old when he was adopted from Russia, and his parents knew that he had a limb length difference, and then that would eventually need to be corrected. So he was originally seen at Scottish Rite when he was 7. And I'm not going to bore you with all the information that I had to read through his chart to find out more about him. But basically, he's a normal 7-year-old with a limb length discrepancy. And at this time, they also determined that he didn't have a right ACL. And the more I researched that, that's quite common with kids who have limb length discrepancies. So this is his actual bone scan, and when he was 7, he had 9.1 centimeters difference, and 7.9 centimeters of that ligament discrepancy came from his femur. He was seen again when he was 9 and when he was 10. Basically same thing, everything checked out okay. It was just for a checkup to see if they wanted to do surgery and when they would do it. The only difference here was that he began having some pain, and he became a little bit more sedentary, but nothing out of the ordinary. His parents weren't really concerned with it at this time. And so here are his bone scans, and when he was 11, He had an 8.7 centimeter difference coming from his femur, and you would expect that because he's a growing boy. So when he was 11 plus 7, he was seen at Scottish Rite. He needed an 11 centimeter block underneath his foot to correct his pelvic obliquity. And at this time, himself and his parents were considering surgery. They wanted it to be done. He was having knee pain, hip pain, hamstring pain. He participated in a basketball camp that summer, and he couldn't keep up with his peers. He did have a shoe lift, but 11 centimeters is not functional. And he fatigued extremely easily. And at this point, 9.4 centimeters of that leg length discrepancy was coming from his femur, so that would be the bone that they would try to lengthen with the lizard offering. So these pictures were taken when I originally started seeing the patient. And just an overall kind of structural assessment, you can see that he stays in plantar flexion. You can tell that one leg is definitely shorter than the other one. He does have some toeing out to help with his balance. And his squat was actually very horrendous, just to accommodate for that leg discrepancy. And then here's an overall kind of gait assessment. So it's just not a functional gait pattern. He stays plantar flex the whole time. He has to toe out to keep his balance. And it was extremely fatiguing for him to walk like that. So preoperative information, every patient at Scottish Rite is seen for gait training with an assistive device by physical therapy before surgery. However, with this particular patient, we knew he was going to be seen as an inpatient, and he was going to stay at the hospital for 8 weeks. So I also took additional examination information when I saw him. And he was going to be checked, or he was going to stay at the hospital for 8 weeks because he came from a family of 18. His parents liked adopting children, and so he has 17 siblings. I think 3 of them were actually his parents' biological kids. The rest have special needs and are from other countries. So his mom knew that she didn't feel comfortable taking him home, having to help him with pen care and with all the things he would need help with. So this is a lot of information, and I'm just going to point out a few things. His pain level was a 2 out of 5, and we used the FACES scale, which has been validated for children. His baseline pain rating was 2 out of 5, which was a little alarming to me, just because when he did even when he was wearing his lift, it was still a 2 out of 5. So I knew that we had a baseline of 2, which I was hoping we wouldn't go above that. Other important things, range of motion and strength checked out pretty well. The right knee had an additional, or plus 5 degrees of knee extension, which was due to his lack of an ACL on that knee. He had a positive anterior drawer and a positive block fence test, which I expected. I just did it just to practice my skills. And from a functional assessment, since that would be mostly what we were focusing on in the hospital to get him home. He had an anterior shift of the body weight, and he flexes his right hip to accommodate the leg length discrepancy when he squats. Overall structural, from the pictures that you saw, he had an elevated right shoulder, which was abnormal because he was left-handed, but it made sense because of his leg length discrepancy. His PSISs were uneven. He stood with a narrow base of support, and his ankle was always in plantar flexion. Just from a basic gait analysis, I mentioned most of those, but the hyperextension of his right knee is what mostly concerned me on that right side. So post-operative information, his surgery was on January 28th, and his weight-bearing status at that time was bilateral lower extremity weight bearing is tolerated, which made sense because it was a boning procedure and he needed that weight bearing to help his bone heal. His lengthening gait, so when he would start turning the struts, it would begin on the 30th, and research mentioned that at that point, therapy becomes a little bit more painful, so I knew that would be something I would have to pay attention to. Objective measurements, there were no changes on the left, and then I was unable to really perform a lot on the right because of his recent surgery. But just from an overall functional standpoint, he had difficulty with transfers. He was unable to walk without a walker, and his gait at that point was with a walker with contact guard assist, and he couldn't bear weight on the right leg, so he was just hopping. And his pain was variable, but he rated it most of the time 4 out of 5 on the FACES scale. So our favorite thing ever, the ICF model. Basically, all of his impairments were related to his decreased range of motion and his decreased strength, and all of those related to his decreased ability to perform functional things, so transfers, gait, and ambulating, or transfers, gait, and then just really returning home. In his participation, I knew he was a son, he was a brother, he had 17 siblings. He was a student, his mom was actually his teacher because he was homeschooled, and then he'd be a long-term patient at Scottish Rite. His environmental factors, he would eventually return home, but for 8 weeks he would live at Scottish Rite. And then personal factors, he is male, 12 years old, motivated, and came from a large family. So diagnosis, plan of care. Overall diagnosis, I determined was difficulty walking secondary to his right lower extremity quad weakness and decreased right lower extremity knee and ankle range of motion. His prognosis was good. He was really motivated. He didn't have any pre-existing comorbidities that would have said he wouldn't succeed. And then our plan of care, which I'll explain a little bit later why I chose this plan of care, would be 60 minutes twice a day, 5 days a week for 8 weeks. And then he would have a home exercise program that he could perform 7 days a week, which I know seems like a lot, but I'll explain. And then our interventions would include Therax range of motion and strength, functional transfers, and gait training. And our expected outcomes were that he would be independent, or at least have increased independence with transfers and gait, so that he could safely go home and not be an increased burden to his caregivers. So our goals, I'm not going to read them to you, but they're mostly related to, I set them for 4 weeks and 8 weeks since I knew he'd be there for 8 weeks. And our goals were related to him being able to complete his home exercise program, gait, and then transfers, which were all things him and his mom expressed wanting him to be independent with before he went home. So are there any questions at this point? Yes.
So I used to teach patients with the Lizarov back in the day. They were super heavy. How heavy is it now proportionally to the kids?
They're really not that heavy. They have a model that they show the kids before they have surgery, and they're maybe 2 pounds at the most. Yeah.
So who tightens the stuff?
So the nurses will tighten it, but the kids are also taught how to tighten it with the family. They're educated so that if they want to do it themselves, they can.
How often do they x-ray?
They x-ray them every 2 weeks. Thank you. Sure. Any more questions? So intervention planning, the Lizarov frame is extremely intimidating looking, so I immediately freaked out when I saw it and knew that that would be the patient that I'd be treating. So the first thing I did was turn to research to kind of figure out some things that I would need to be aware of and precautions. And basically all of the research said that these kids do extremely well in physical therapy, and that's actually the best treatment for them. Subluxations and then joint contractures at the hips, knees, and ankles are the most common problems you run into with these kids. And then because most kids with limb length discrepancies do have some type of ACL aplasia, I also knew that I would have to be aware of that. So focusing on his knee subluxation and preventing that from happening would be extremely important. So I was actually really surprised when I looked into research that there are a lot of research articles that were actually done by physical therapists, and they provided basically their outline of how to treat these patients. And so this was one done by a physical therapist, and they focused on bend mobility transfers during the first week, basically becoming more independent. And then after that, moving on to doing strengthening and range of motion. And so I knew these were all things that we would focus on in therapy because we needed to get him home. So phase 1 and phase 2 are what I really focused on with my patient during the 8 weeks. And then I also ran into these clinical guidelines. They were produced by 12 specialists that deal with Ilizarov frames in the UK. And they had a list of treatment ideas or things they thought were important. And all these therapists rated them on a scale of 1 to 9. If anything had a score less than 5, it was excluded. But they basically came up with clinical guidelines of what they thought was important to include in the treatment plans. And so these are the guideline statements. And basically, I just looked at the scores. So range of motion, gait training, stretching, transfers, and mobility, lower limb exercises, all these things were important to them. So they have scores of like 8.6, 8.9. So, moving on. So this is the actual home exercise program I provided to my patient. He was going to do 100 repetitions of each exercise daily. 30 of those repetitions would be performed during one of the sessions of physical therapy with me. And then the remaining 70 he would perform on his own time with a nursing tech or with his parent. His parents came and visited him daily. And so we included ankle pumps, quad sets, glute squeezes, heel slides, gap stretches, hamstring stretches, short arc quads, straight leg raises, snow angels or supine hip abduction, stretching, and then leg hanging, as well as these, which were more advanced. And so obviously I didn't give him all of these because a 12-year-old boy is not going to do all these exercises. But that's why I had him do 30 repetitions with me, and we'd come up with a daily plan, modified plan of these are the exercises, and I mark them. These are the exercises you're going to do today, 100 repetitions. And so we'd come up with about 4 or 5 exercises that he would perform. And then 100 repetitions is a lot more than the standardized 10 that you see a lot of physical therapists giving patients. And it's also not what we're taught in school by any means. But strength, power, hypertrophy, muscle endurance, all these repetitions, they all kind of overlap. So I thought by him breaking them up into smaller sections and doing them on his own, he'd hit strength, power, muscle endurance, all those things, because they all work in conjunction with each other. Well, I don't know why you need permission to do that, but it was a video of him doing a straight leg raise, so that was kind of a progression. At the beginning, he was able to do none of the exercises on his own except for ankle pumps, and those were even painful for him. So progression and modifying, we would do the home exercise program together in therapy and also work on gait training. So as he progressed, he needed less and less hands-on help. So straight leg raises, I'd have assistance, and he was able to do it without assistance, without me holding his leg. Same thing with supine hip abduction, things like that. And then from a gait standpoint, when we practiced, we would do that during our other session, and we'd go on walks down the hall, turn it into games like basketball, go on scavenger hunts. We'd walk down to the park, take the elevator down to the park. But he started out with a rolling walker, and that was even really hard for him. And then we moved on to 2 crutches and then to 1. So he got discharged with 1 axillary crutch. The pictures in the middle of the Velcro straps, the bottom picture is actually his Darko shoe. So he had a Darko shoe on, and we took that Darko shoe down to orthotics and had them put the 11 centimeter lift on it so that he could walk evenly and wasn't having to be on a plantar flexed toe with this huge frame on his thigh. And then one of the articles I read suggested that patients have a lot of trouble achieving that dorsiflexion, and so they used some kind of elastic strap to pull their toes into dorsiflexion. So we took the Darko shoe down to orthotics and had them attach Velcro straps to both sides of the Darko shoe. And then wrapped those around the tops of their frames because that frame is really stable. You can actually lift. That's how I assist him with his exercises. You pull from the frame and it doesn't hurt him at all. But that provided him some extra support for dorsiflexion so that he could get toe clearance during gait because he'd often trip on his toe because he was just used to being in that plantar flex position. And so these are his measurements. At that point in time, I wasn't necessarily very concerned with them, but I did take them, so I had objective measurements. And the other thing I had to be really careful about was knee flexion. I wasn't pushing it like you would push someone who had a knee replacement. I wasn't concerned with achieving that because I didn't want his knee to sublux. And research says that these kids tend to get knee flexion back on their own, even if you don't push them. So I didn't push him too much with knee flexion. Whatever he could achieve is what we stuck to. So the home exercise program sounds pretty boring in itself. So as he became stronger and more independent, we moved on to more functional, more fun activities for a kid. We had a Wii balance board that we worked with, and I was a little bit worried because a 12-year-old boy, video games, we weren't going to get a lot done during therapy, but the Wii balance board has actually been shown to provide real-time feedback for weight carrying status, and we had a lot of trouble with him bearing weight on that right side or putting his full weight on the right side because of pains a little bit, but also because it's really intimidating to be 12 years old and see pins going in and out of your leg. So we worked with that, so he enjoyed that game a lot. Other things we did would be, we would kick the soccer ball because he can also move his leg, shoot the basketball so that he'd have to step and shoot. But that was more towards the end. We probably did that for a week and a half as he became stronger and more independent, and I didn't have to stand there and guard him the whole time. So outcomes and termination, these were his measurements when he was discharged. He was discharged on March 14th. When we did discharge him, we just made sure that he stayed in extension most of the time. We didn't want him to get into that flex position because of subluxation, because of his lack of an ACL. And I wish I had a reason that we discharged him on that day, but the only reason I have is because that's when his mom wanted him to go home. So the physician signed off on it. We felt comfortable with him. He was independent with his home exercise program. So I had they're saying him staying. So clinical relevance, new patient populations, you're not taught everything in physical therapy school. And so you have to be able to turn to literature and not be afraid to treat these patients. So those are all incredibly, incredibly intimidating, but you have to treat them. Function, we've heard it forever in class. It's extremely important especially for this population and for the setting I was in. I wasn't concerned with getting him back to 100%. I was concerned with him getting home. So we worked on a lot of functional things, even though it wasn't necessarily fun. He had to be able to do it to get home. Pain assessment with him, pain was a big issue. Psychologists had said that he had trouble expressing abstract thoughts. So pain is kind of an abstract thought for kids, even though the FACES scale is 1 to 5 and has pictures. So when he would rate his pain, in one session, he'd rate his pain at a 2 and then a 5 and then no pain. I was extremely frustrated with that because I'm like, okay, we have a pain medicine schedule, but you need to let me know. But I actually went to research for that, and it said that when kids are asked to rate their pain, they actually underrate their pain when they're asked by medical professionals. So when he was rating his pain at a 5, I did have to listen to him and adjust my program based on that. And then this is a pediatric population, and it was a very interesting population because it's not just pediatric, it also involves ortho and acute care. So it's kind of like this whole accumulation. And I also had to adapt what I learned in school for kids. So limitations, solutions, and second chances. The biggest limitation I had with him was his lack of an ACL on the right side. I was extremely afraid that it would sublux because that surgery is so intricate. They have 2 surgeons that do that surgery, and they're very particular about the way you do things. So I was a little hesitant with some of the exercises we did, and if I had a second chance to go back in time, I'd probably work on knee flexion a little bit more, not push him, but work on it a little bit more, because I think it would have helped his gait. And then just making my exercises for him a little bit more fun. I tried the best I could, but and being in a hospital, you're also kind of limited with the resources you have. Are there any questions?
So you mentioned being nervous, it's like handling it, and kids probably getting into different positions because they can be put in pretty much any position as long as you're kind of careful. How did you sort of get over that barrier? How did you handle your own psychosocial reaction, your emotional reaction?
So I knew from like research and then from talking to my CI also, I knew that they could do it. So I just kind of sucked it up and was like, today we're going to go onto your stomach, and that's what we did. And it wasn't always fun. It does hurt them, like their bone was cut into 2 pieces, but we still did. I mean, I gave him some help and showed him how to do it, and we'd get to that position together, and he'd lay on his stomach and get full knee extension. It was definitely I'm not a huge fan of ortho, but this really helps me bring out my ortho skills.
Yeah.
It doesn't go away. Everything, it all works together in physical therapy.
It does. Yeah. I think this is a great use to show that. It's not something we spend much time on in school at all because you don't see it unless you're in that type of setting, but it's a very common feature, relatively speaking. For you.